So good afternoon and welcome. My name is Harry Macmillan. I'm one of the directors of Momenta. That's the provider of the NHS Type 2 Diabetes Path to Remission programme. We'll be running through a number of slides, but as I said, if you have any questions, please, or comments, please type them into the chat. We'll have time for questions at the end, I hope. So first, this is what we're going to cover. Just go through the background and benefits of the program, the actual program itself, roles and responsibilities between us as a provider and yourselves as primary care, and then a section on medication adjustments. That's both deprescribing and potentially retitration later, the searches and referral forms, and next steps. In terms of the background to the program, so I'll assume that if you're here, you probably didn't make the previous education session in August, or you'd like a refresher. So I'm just going to go through this quite quickly. You'll obviously get all the slides afterwards, so you'll be able to see everything on those later. So the program itself is based on two studies that have primarily informed it. One is called DIRECT, and the other is called Droplet. And they both basically showed that remission of type 2 diabetes is possible at scale in primary care. And DIRECT is the study that's informed it most. That was based at University of Newcastle and University of Glasgow. And we have had the privilege of working with some of the team from the Newcastle University in developing our approach and program. In terms of what DIRECT found, the intervention group at 12 months, just under a quarter had lost 15 kilograms or more, and this is from a lifestyle intervention, so not pharmacological. Just under half had achieved remission, and just over a third in total had maintained remission at 24 months. And there are fewer adverse events in the intervention group than in the control group. That's a very whistle-stop summary. In addition to that, remission was very closely linked to weight loss. So the more weight people lost, the greater the chance of remission. And that was a very linear relationship. And what's less well publicized is that the fewer medications people were on, the greater their chances of remission as well. So the only other point is that I am so sorry, there are supposed to be slides. Yes. Should be able to see them now. Thank you, Amanda, for pointing that one out. So remission is closely linked to weight loss, and the other point is that for the purposes of this NHS program, remission is defined as having an HbA1c of less than 48 millimoles per mole for more than 6 months on no medications. There's a different consensus group definition that looks at 3 months, but your patients is probably fairly academic. For the purposes of coding, it is 6 months, but we will let you know that nearer the time. In terms of benefits for patients, they're pretty significant. And in 20 years of working in this and related fields, I can clearly say that the remission program can have the most significant benefit for individuals that we've been working with. And that's despite us, our program being used on the NDPP program and weight management programs as well. So we're not saying it as a kind of compared to other providers or other approaches. We're just saying it compared to the other programs we've had the pleasure of working on. The weight loss can be very significant, as you've seen from the DIRECT study, and the impact on medications is equally significant, as well as improvements in various comorbidities and increase in quality of life, and also a reduction in CVD risk. Also the whole program, all the coaching and all the formula products, the total diet replacement products, are free for patients. They're all paid for by NHS England. There are some case studies there if you want to click on these later to have a look. And finally, there are also some benefits to practices. Obviously, it's free because it's commissioned by NHS England. Referrals are eligible for the weight management enhanced service fee if you're signed up for that, and the referrals are appropriate. There's also, probably more usefully and relevantly, there's a range of anecdotal evidence from when we've been delivering it so far that shows or indicates a reduction in use of practice services by patients on this program. So as they start to lose weight, and so they get some of the benefits, not just from their diabetes, but also on their comorbidities. So they experience less pain, for example, fewer mobility issues, and other benefits that result in them going to practice a little bit less. But that is anecdotal. It's not evidence-based or thoroughly evaluated. So in terms of the program, it started off commissioned by NHS England as the NHS Low Calorie Diet Programme in 2020 across about half the country over a couple of years. And it's shown similar emerging results to Direct. And it's now a national framework like the Diabetes Prevention Programme. And in Bain, Swindon and Wiltshire, the referrals started from early August. Secondly, from our point of view, in case you don't know, a likely event you don't know who we are, we've been providing this service since 2020. We were one of the original providers of low calorie diet. Sorry, could whoever's just joined pop on mute, please? That'd be very helpful. We are currently providing the service in about just about a third of the available areas. It's then by April next year will be across the whole of England. We have been running in Somerset as a close neighbour of yours for the last year and a half or so, and the early outcomes of our work are also in line with both Direct and the other pilot providers. So, what is the programme and who's it for? So it's takes 3 phases over 12 months. So the first phase is the total diet replacement products. So that is 12 weeks or 3 months of 800 to 900 calories, 4 products a day. The next 6 weeks are the food reintroduction stage. And the food reintroduction is 1 main meal every 2 weeks. And then finally, up to a year, there is support for building healthy eating and activity habits into daily life. I say finally, but that third phase is really fundamental to success in this program. It might sound odd, but it's relatively straightforward. We've seen for people to stick to the first phase. So the shakes and soups. Once they've made that decision, it's a fairly binary decision, and it's counterintuitively really against what we expected when we were developing the service. It seems that's almost the easiest bit to stick to. And then, like all behavior change, the maintenance and the sustainability and changing underlying eating patterns over the next, sort of the third phase, is the most difficult to both stick to and where most support is required. I mentioned that only because it's not what we were expecting at all. And then the delivery format now, since the 1st of June, in most areas, it's the patient choice of either in person or digital, digital with an app. Both of those are 1-to-1, and they both have support from a trained coach. Other partners involved in this, the total diet replacement product supplier is called Exante. They have the widest range we could come across of flavors and textures on the market. We have an app platform for our digital program that is provided by an organization called Habitual, who originally developed their app for diabetes remission services, so it's very relevant. But we use it with our content and our coaches, so that there's no kind of choices for better or worse across it. People get the same content, just a different platform. Our coaches receive comprehensive training, obviously not just in the program, but in a range of other operational aspects. And we prefer them to have a nutrition qualification, but it's not required. In terms of the contract, it's for the NHS England have commissioned us to deliver to 500 starters over 2 years. Although they have indicated that they would be amenable to increasing that if we get lots of referrals from you, and it looks like we're going to get through that 500. That's not 500 referrals, it's 500 starters, and it's slightly different from that, but it's not worth boring with the detail. So who's it for? These are the inclusion-exclusion criteria. I shall leave you to read the detail of these when we send the slides around, and it's all copied onto the referral and medication adjustment form as well. But some of the key ones which people don't always spot, or which occasionally cause a little slip in the referral eligibility perspectives, are the upper age limit of 65, and also it's only for people who've been relatively recently diagnosed with type 2 diabetes in the last 6 years. The HbA1c limit is the lower limit to what you'd anticipate, and the upper limit of 87 is there for everybody, whether they're on medication or not on medication. Again, that's one that sometimes gets overlooked. Penultimately, your assessment as healthcare professionals has an overriding trump card, irrespective of whether someone is eligible. If you don't consider it's going to be safe to monitor their medications, or potentially retitrate them if required, or for any other clinical reason, then you can decide not to refer them. You can decide not to refer them anyway, but there's a very clear clinical judgment trumps all these guidelines. On the exclusion side, unfortunately, not on the inclusion side. And finally, anyone on insulin is not eligible. So what does the program look like? Again, I won't go through all of these session titles and topics in detail, just in case anyone has an interest in the kinds of things that are discussed or the focus areas over the 3 phases of the program. That's the first phase. There's obviously much more around the behavioral change and support and psychological support to sticking to the total diet replacements. Then we move into the starting to focus on healthy eating and increasing activity levels. And then the third phase is what you'll normally see in, for example, diabetes prevention programs or weight management programs. But it's flipped, because people are starting phase 3 from what is often their lowest weight that they've been for some time. So normally, so it's a different positioning, but it's a lot of a similar content. We also provide lots of resources and obviously access to the app for the digital participants. Meal replacement products, I've mentioned Exante have the widest range we've come across when we've been reviewing market providers of total diet replacement products. Your patients will order directly from a Momenta Exante landing page, and we give them voucher codes for each of their orders, which last about 4 weeks at a time, give or take. If they have any issues doing that, we can support them both over the phone or doing it for them in person. On the online if required. That's a longer process, but most people, it's a very simple website, so most people are happy with that approach. In terms of resources, this is just to give you a rough idea that people get a range of well presented and interactive resources. The digital pathway also receive monitoring equipment, so scales, blood glucose meter, and blood pressure monitor for anyone on blood pressure meds at referral, and obviously the app as well. And just to give you, and I'm not going to go through the app, don't worry, but just to give you a very quick snapshot, you'll see the bottom toolbar here it's very intuitive. It's got a nice look and feel, and it's got all kind of functionality you expect on an app in terms of the content, the tracking, etc. There's also a few interesting elements of gamification built into it as well, which makes it a little bit different from some voucher rewards as well if people stick to the program and do very well on it. So moving into the roles and responsibilities, I'll spend a little bit of time on this slide because it's quite a significant one. So obviously we need your referrals before we can start to deliver the service. So the first port of call is making referrals, and we'll come on to a bit more detail shortly about different ways you can identify interested patients in your practice and some of the support that we provide you to assist with that. So once you've identified the patients, you've done the medication adjustment, deprescribing appointment with them, and you have sent us the referral and medication adjustment form, then we will basically start the process from there for the actual service itself. So it starts off with a registration eligibility check call. There's then an individual assessment and then booking onto the program. If people have time, we can combine those. If they prefer to split them out or want a bit more thinking time, then we can split out the calls as well. Once they're through that kind of booking, and at which point in the individual assessment they choose whether they want to do in person or digital, then we move into the program itself. So the 3 phases: phase 1, phase 2, and phase 3, before completion, and hopefully completion and signposting at any discharge point. Over the course of that program, we will communicate with you at certain times that NHS England has set out. So, for example, on the start of their total diet replacement, because it's important that you know when your patients are starting total diet replacement, we will also communicate with you when, or if and when, any of your patients, if the measurements that we monitor at every session or session equivalent for the digital participants, if their measurements go outside of NHS England thresholds. So, for example, if their blood glucose is over 15 for a couple of sessions in a row, or over 20 on any individual session, then we will write to you. As I say, we monitor those safety measurements at each session, or for the digital participants, each session equivalent. And we will also signpost on discharge. Because it's a one-to-one service, some of the pilots were group, but because now it's a one-to-one service for both in-person and digital delivery, we've found that some practices are keen, if they think they have lots of potential patients who might be relevant, or even a few, they're keen to have it delivered at their practice. So if you're interested in talking about that with us, because you'll all have rooms, consultation rooms for one-to-one, which you might or might not make available for these kinds of services. But if you do, then we're very happy to talk to you about delivering to your patients and maybe nearby patients from your practice. So we typically run these sessions in small clinics of maybe a couple of hours, 4 hours, or sometimes a little bit longer, depending on the volume of referrals. So there's a link there to drop us a line if you're interested in having the service delivered at your practice. So that's the roles and responsibilities. The only other thing I should say is that after referral, you are required to do a repeat HbA1c at 6 and 12 months. That's for fairly obvious reasons, but also to understand if the patient achieves remission or not. Often, at least one of those can be part of your standard annual review, and the timing can be changed a bit, is what we've found. So it is extra work, but it is not a huge amount of extra work, and we will send you a reminder in advance. You don't have to diarize anything, and we'll also remind patients to ask you for them. The other activity that you'll need to do is, if your patients either exceed or go below the monitoring thresholds I mentioned, then it will be appropriate to bring them in for a medication review. We'll come on to what that means in practice in due course. And it does happen, but it doesn't happen nearly as often as it did in the direct trial, for reasons I'll also come on to. So it's definitely the minority of patients for whom that happens, but it is something that does occur. So ways to identify interested patients. So basically 3 choices. The first one is doing a search and invitation, which you're probably familiar with from the NDPP. So search of your practice register, a screen of the search results, and then sending people a text, or potentially a letter if you prefer, but a text and a landing page link, both of which we've templated, and a letter with a leaflet if you want, which we can also provide to you. The second way is doing it opportunistically. So this is, for example, on diagnosis or on annual reviews, or maybe medication reviews, or potentially at patient request, if they hear about it from somewhere else outside of the practice, they might come to you and ask for a referral or for a referral appointment. And the final way, this is more of a bespoke way, and we don't suggest that most practices do this, but if a practice is particularly keen or they have a hard to reach population you'd like to engage with, or you think that your patients generally benefit from in-person rather than text or letters, in-person discussions, then we can support you to put on a patient event at your practice. We've done that in quite a few different places around the country. If it's done well, which involves a fair amount of prep on both sides, a bit of support from us and also a bit of work at your end, it can be really, really effective. But it is additional work over and above the standard. So we'd only suggest you do it if you've got a good reason or particularly strong desire to do so. But if you do, we'll be delighted to support you. There was one, and they can be done not just at practice level, but at cluster or PCN level. So there was a PCN in Somerset that did one last week that resulted in 25 referrals, which, to put it in context, is about the slightly under the monthly referral volume across the whole of Somerset. So it can work very well, but there are some things we've learned about what to do and what not to do. So the opportunistic is the one that is most relevant to your patients, and the search and invitation is the most efficient way for you to do it as a practice. As I mentioned, we support these approaches with leaflets, with a poster for practices, and these are all downloadable on our website, which we'll provide the link for later. And this is the patient landing page where you can signpost potentially eligible patients and they can go and read a bit more about the program. So the only people you have referral conversations with are those that are genuinely interested and think that it's ready and it's the right program for them at this time in their lives. So that saves a lot of time of a discussion with potentially eligible patients who this approach just isn't for. So the whole purpose of the support we try to provide is to make it as efficient and effective for you as possible. So if you, over the course of making referrals, come across things that you'd like us to develop or ideas you think we should pursue, or just want to give some feedback as to ways that this can be improved for you or your colleagues going forwards, then we're all ears, because the more efficient this process is, the better for everyone. Right, so now we'll move on to the medication adjustment section. It's called medication adjustments, not just deprescribing, because the first part is deprescribing, but there can be retitration afterwards, as I mentioned. The most important thing to say is that all of these changes are medications changes that your patient should only make on the first day that they start the total diet replacements. So you'll refer them. We'll then go through the eligibility checks and individual assessments at a time that suits your patients. They actually book times that suit them in with us. And depending if they've got a holiday coming up or anything else, it could be that they could start the program a week after you refer them, or it could be 2 weeks or a month after you refer them. So it's important that they understand that any changes to medication are only to be made on the first day they start the program. Now, we'll obviously reinforce that, so it's not all down to you, but it's very helpful if they hear it from you first. So the logic for deprescribing is probably best illustrated by a couple of graphs from the counterbalance study. This preceded the direct study and done by the same team at University of Newcastle. So on the left, you can see blood glucose levels after stopping glucose-lowering agents and starting total diet replacement products. So exactly what they'll do on the on this service, and you can see that the blood glucose levels came down very sharply in 1 week and continued to drop over the next few weeks. On the other side, on the right, is looking at blood pressure. You can see that there was also a reduction in blood pressure, but not as marked and not as speedy, but it did continue in that way. So, but importantly, that was after patients stopped all blood glucose lowering medications and all blood pressure lowering medications. The approach that NHS England have taken is much more conservative than that. So more likely to or less likely to result in people needing retitration. So obviously, starting medications is more familiar than stopping them to most. So we're aware that this can be a little bit off-putting, but actually the NHS England guidance that they've developed with the expert reference group is designed to be safe, evidence-based, and pragmatic. It's a lot more conservative and direct, as you'll see in due course. And fundamentally, two things. One, the patient remains your clinical responsibility throughout the service. And secondly, these guidelines do not replace your clinical judgment. They are guidelines. So in terms of the blood glucose medication first, and initially deprescribing, as you've seen, the blood glucose levels drop significantly on the first day. So that's when they should adjust their medications. And you'll see this repeated several times. I won't repeat it every time because I've said it now a few times. That's quite enough. But it's an indication of how seriously it's, or how important it is to do it on that first day. So the deprescribing is relatively simple for the vast majority of patients who are eligible for this service, because don't forget there's a upper age limit of 65 and it's diagnosed within the last 6 years. So it's relatively recent. If your patients are on 1 or 2 glucose lowering medications, then you should stop them all. If they're on none, obviously there's nothing to stop, so that's easy. If they are on 3 or more, then you should continue with metformin only, or if they're not on metformin, a gliptin or a pioglitazone. Now, importantly, as you'll probably be aware, sulfonylureas, glycinides, and SGLT2 inhibitors are not safe with total diet replacement products and must be stopped. So if you're making any choices about what to stop and what not to stop, those medications must be stopped. And NHS England also recommends stopping GLP-1s, partly because they're more difficult to get hold of, but also from a cost point of view. But it's not a safety issue. There's another table in here, and I should also say, sorry, there's a significant pack of guidance for the whole service from NHS England, which is also available on the website details that you'll see. That has more information in it. This is a summary of those. So this table is in there, so you can see the medications that are not safe with total diet replacements. If you prefer it in a flowchart form, here we have it. No agents, continue straight. So do the medication adjustment form and provide a copy to the patient. That's very important. If they don't have a copy or know that they know what to do, and they can't tell us that they know what to do, then we have to send them back to you to get a copy. You'll send us a copy of it as well, but we can only give it to them if they actually have a good recollection of what you asked them to do and just need a prompt. We can't give it to them if they don't remember. They have to come back and be told by you, not least in case they've changed medication and they can't recall that either. So even if there are no agents, it's ideal if you can give them a copy of the form. If they're on 1 to 2, stop both. And if they're on 3 or more, stay on metformin or other first-line agent. Insulin is an exclusion criteria. And if they are on medication and you reduce it or stop it, then please cancel them about osmotic symptoms and seeking support. We will do the same, obviously. And finally, obviously, it's about using your clinical judgment. So that's lowering blood glucose medication. In terms of restarting it, so if the threshold, if they exceed or if they come out of threshold and you need to restart medication, for example, their blood sugar starts to increase. So we will let you know at certain thresholds. We'll actually also let you know if so our medical director is a GP specializing in diabetes, and if her view is that if it was her patient, she would like to be told, then if people maintain a higher elevated blood glucose for a period of time, significant period, then we will let you know, not as an urgent notification or anything, but just as a kind of FYI. But fundamentally, if you want to restart, we've talked about the ones that are safe. the ones that are not safe, sulfonylureas, glycinides, and SGLT2s. And if you decide that the patient should go on to insulin, then they will have to stop the program because that's an exclusion criteria. So that's blood glucose lowering agents. On to blood pressure lowering agents. If their blood pressure is raised, then you shouldn't make any changes. So that's simple. And we'll start off with medications that focus on that are for blood pressure, but blood pressure, a number of other medications also lower blood pressure that are given to patients for other reasons. So we'll look at both of those in the following slide. But if their BP is within range, both on systolic and diastolic, then the suggested way forward is to reduce one agent, or to paraphrase, go one step back in the NICE escalation, but again, only on the first day of TDR. So it's important on the blood pressure lowering agents to check which other agents they might be on which lower blood pressure that are not for their blood pressure themselves. So whether it's for heart failure, angina, migraines, etc. If you can, and they're on an agent which is purely for blood pressure, then that is the one to focus on, and to stop the one which would have been added last according to NICE guidelines. So we've got a little order section here on this slide. And finally, if the patient is taking blood pressure medications that are all not primarily for blood pressure, but they affect their blood pressure, then you should cautiously reduce the dose of one or possibly more, but in discussion with your patient. So that's a joint decision making, and again, clinical judgment is yours to apply, but in the knowledge that their blood pressure will come down when they start TDR products. So here you have it in the flowchart form for reference. And the only other thing to mention is about counselling your patients about postural hypertension. That we have seen a few instances of that, particularly over the summer, combined with dehydration. We obviously strongly advise and repeatedly advise remotely and in the sessions, people make sure they're drinking enough and staying hydrated, especially when it's warmer, although we've been spared a bit of that this summer. I guess that's an upside of a good British summer. But it is important that they're aware of postural hypertension symptoms and about what to do about it. Again, the referral and medication adjustment form should be completed even if they're not on medications. In terms of subsequent retitration, again, it's following, it's basically just up titrating as per NICE guidelines if the blood pressure is too high. If the blood pressure is too low, then it's repeating the process you've just been through. Again, going down one step as the default. And again, if the agents are specifically used for managing blood pressure as the solely used for that, they're the priority to adjust. Right. Finally, there are some other medications that might need adjustment if they are impacted by changes in weight or diet. And some of these might not be prescribed by you, they might be prescribed by other services. So the key here is to ask yourself, if someone lost weight or had a major dietary change, is the dose of the medication likely to need adjustment? They don't lose, their weight loss is rapid, but not immediate on the first day they start TDR. So obviously, again, it's exercising your own judgment. And it might be about making a note to reevaluate that patient a few weeks into the TDR phase, and making sure that they're aware of what they should be looking out for. But if you are not comfortable that those medications can be reviewed and can't be done safely, then you should not refer to this program. And here are some examples, by no means exhaustive, but some examples of medications that are impacted by changes in weight or diet. Again, these will be in the slides, obviously. So that was the medication adjustment section. we'll now move on to looking at searches and referral forms and about how to make a successful referral. We've already talked about identifying and inviting eligible patients in those three ways. So the search, the opportunistic way of doing it, and potentially the bespoke event. Once you've identified your patients and they've come back to you to say, yes, they're interested in this service, then the next step is a referral appointment. This is where you'll talk to them briefly about the service, but the focus of this tends to be the medication adjustments once you've ascertained that they are indeed ready to start this service. Typically, we're told it takes about 15 minutes on average, so that includes the time to review the record beforehand, a discussion with the patient and to make sure they understand the medications adjustments if appropriate, and then also to do the admin after you've had that conversation, complete the form and send it to us. Importantly, provide them with a copy of the medication adjustment form. You don't have to provide the whole form if you don't want to with the referral section, but it's perfectly easy, straightforward to do that. And finally, don't forget, send it to us. And that's the contract-specific NHS inbox that we use for this. The searches are on Ardens and the referral form. So if you search, for the search, you look for T2DR path to remission, and for the referral form, you look under T2DR. Again, these slides I'll come on to in a second. There are three slides that show for each of Baines, Wiltshire, and Swindon where the search is. The referral form itself is looks lengthy, but it's largely auto-populated. The main bit that needs attention outside of a few places where it's not possible to auto-populate and there are checkboxes or comments for additional information if required, the main section that requires your input is the medication adjustment form, which is on the last page and a half. The reason it's on the last couple of pages is so that you can print it off and give it to your patient if you want to, if they want a printed copy rather than electronic. In terms of where the search is, there's a slide in here for each of Baines, Swindon, and Wiltshire. Again, I'm not dwelling on them because you'll have the slides. As far as the searches and referral forms are concerned, I think the main things that we come across are on the searches. First, to sense check the results. The searches are obviously dependent on the coding, the input coding, and occasionally we've found, due to largely historical issues, that can return some unusual results. So it is important just to sense check them and ideally do a manual screen. Some practices don't do that because the landing page has the majority of the eligibility criteria on, but generally it is good practice, so to speak, to do so, because then you're not sending your patients information that isn't relevant to them or might not be so relevant to them. And if you find you get a large number of patients returned from your search, then you can either review them in batches or you can triage them. One of your colleagues suggested starting off with the patients who are on metformin only or no medications because they'll be quicker, and it will enable the people in the practice making the referrals to get used to it and get used to the process before then moving on to patients who are more complex. So that's certainly one way of doing it, or just alphabetically or however you like to. And that's if you're using the searches. Some of you will just be doing this on an ad hoc basis and opportunistically. So, yes, I will share the name of the search again. Oops. It's T2DR path to remission. Hopefully, you can find that, and if not, we'll pick up afterwards. But these are, I guess you're in Baines, so the search should be, he says, reading this slowly, in the diabetes and endocrinology section under T2DR path to remission. hopefully they're there. As I say, we'll share these afterwards. So, but if they're not, it'd be very helpful to know, because then we'll let everyone else know as well. This is what we've been supplied with, so I'm hoping they are. Okay, back to these. The next point is on the referral and medication adjustment form. So obviously, importantly, just to confirm the eligibility before you proceed. That might sound obvious and like I'm trying to teach you to suck eggs. I'm really not, but we do get some. Thank you. You have no slides. I'll forward the slides, but yes, I think the searches should be there. Nikki, if you could mention in the chat if you did find the searches with those, that would be very helpful. Or if you haven't had time, don't worry about it. I'll send them later. So yes, it's helpful if you could confirm the eligibility criteria. Again, we do get ineligible referrals, which is thanks, Nikki. Which is frustrating for you as well as for us, because you spent time going through that process for someone who's not eligible. Okay, thank you, Connor. We'll look into that. And when I say we, I probably realistically mean Joe, if that's okay, Joe. Would you be able to look into where the searches are? That would be very helpful. Thank you. Okay, so on the we'll follow up with that when we circulate the slides. Yes, so if you confirm the eligibility criteria, that would be great. And if they're not eligible, it will obviously save you time as well. If you ensure the patients have a copy of the medication adjustment form, or at least are very clear on the medication adjustments they should make, that would also be helpful, because as I say, if they're not, we have to send them back to you. Unfortunately, there's nothing we can do about that. And there's a couple of check boxes to tick at the bottom, at the top of the medication adjustment form. If patients don't require any medication adjustments, if you could tick them, that would be very helpful, because then we won't have to chase them. Thanks, Nikki. Sorry, I misread the. It must be the longer ICB bit after your name. I just saw Bath and North East, and I thought that would be Baines, but apologies. So if we don't get that information, we have to come back to you to request it, which just takes up more of your time. We're obviously very happy to do that, but it's not a good use of your time. So this slide is what I've taken to call in the Brian slide, because Brian Leach, who many of you will know, suggested it'd be helpful to have the service on a slide picture. So it has the pathway we talked about in terms of the default approach being running a search, manual screen, sending text and link or letter and leaflet, then doing the referral appointment, sending us the referral medication adjustment form, and finally going onto the program, but in blue as the primary care bit, also doing the repeat HbA1c at 6 and 12 months. There are some ad hoc ways of doing it. So identification and inviting, which we've talked about, and that's fairly clear. And then there are also some optional or potential steps. For example, the inviting to an event. You might want to send people a repeat text or reminder call if they don't respond to you the first time. But again, that's entirely optional and depends how you normally do these kinds of approaches. We provide our contact details so the patients can call us if they have any questions about the service, so they don't bother you or your colleagues in practice. Then if there's any missing information, we'll obviously follow up and ask you for it. And we'll also let you know if they need any medication review. So the grey bits are what we do. So hopefully that's kind of color-coded service on our page. We've also got the relevant links down below. We will supply you with all of the SNOMED codes at appropriate points in time, with the exception of the first two. So if you invite them, or they decline. We obviously don't know that. So they're the two codes that you'd have to enter directly yourselves. And then you've got, we will host drop-in sessions once a week, which you're very welcome to come to if you've got any follow-up questions. There's also the patient landing page link, the referrer landing page, referrer support page link, and then our inbox for any referrals. Glad to know that's almost it. On to next steps. Any questions, any more questions apart from not being able to find the search and referral form, which Jo said that she's going to send you screenshots of afterwards in case you haven't seen that in the chat. Thank you, Jo. We'll follow up with this follow-up by email with these slides and some additional resources, the pathway slide, NHS England guidance, and also a link to the recording. I'm sorry, I thought I had changed this. It was a soft launch from today was the August training. That's actually the real launch has already happened. So we're now fully up and running as a service. So apologies for that, not catching that. If you want us to deliver the service or you want us to talk to us about delivering a service in your practice, let us know. If you'd like us to attend any other events you have, whether it's PCN level events or other practice events, to talk to your colleagues about this in more detail, not in this amount of detail, I hasten to add, unless you want it, but in a small snapshot, then we're very happy to, whether it's 5 minutes, 10 minutes, or whatever it is, whatever suits your format. And if you have sent us referrals so far, thank you very much. Just so you know, we've had 32 referrals so far, which is pretty good for a soft launch over the summer. We were amazed, to be honest. So I think you've done really, really well collectively. And looking forward now after this session to starting to ramp that up even more. And we've got one page at the end of here, which has all the relevant contact information. So the inbox for referrals, the referrer resource page and the participant page. The booking page to register for any of the drop-ins for ongoing support. We haven't got a session for the next education, a date for the next education session yet, because this was the, we had one in August and one now. We're not planning anymore because we'll make this recording available, but we might maybe later on this year or early in the new year. Then there's a page of case studies, both written and video, the link to register interest in delivering your practice, and finally ICB and Momenta contacts. Anna is my colleague who is an engagement lead, so she's the one who'll be working with you most closely to support you with any of the standard details around the service and how to make referrals. But I'm also available if you require, if you haven't had enough of me so far, which you might well have, in which case feel free to email Anna directly. But otherwise, either of us, whoever gets to it first, will get back to you. Okay, so that is it. You'd be glad to know from us, and over to you for any questions. And thank you very much for listening if you haven't dozed off yet over lunch. And thank you very much for attending, because without referrals, we obviously can't deliver the service. So we're very happy to have had your presence and also to have had the opportunity to share this information with you. Thank you. And we've got a few minutes before the end of the session, so if you have any questions, feel free to shout or put them in the chat, raise your hand, whatever suits you. I'll keep an eye on the chat. So try to look at hands, but if you don't get a response, just ask. And I'll also stop the recording.